Good,
Uh,
Dr. Vinod, if you're good to start, we can start the process.
yeah. Can you hear me, ma'am? No, I was just trying whether you can hear me. All right. Good morning, everyone. Can you hear me? Yeah. Can you hear me?
Doctor, we request you to mute one of the devices so we can hear clearly.
Is it fine now?
Yes, doctor, please go ahead.
Yeah. So good morning, everyone. I'm Dr. Vinod, and on behalf of my team, under the advice of Dr. Radhesham, and in collaboration with the Global Healthcare Academy and Healthcare Global Bangalore, we have initiated this course. This is basically an immunology course with focus on cancer. So we will rather call it as oncoimmunology. So to begin with, Global Healthcare Academy, this has been instituted with a certain mission. This academy intends to develop the competent and compassionate human resources for healthcare sector. So what we mean is that we run parallel to an organized, a university or an institute, but at the same time, the skill building, the translation which has to happen from the bench to the bedside. So that is where the Global Health Academy plays its role. We want to kind of come up with innovative solutions and certain entrepreneurial innovations in healthcare. So the core purpose is to bridge the skill and the knowledge gap. We have a certain know-do gap which exists. What it means is we have a few concepts in the mind, but how do we implement it? So the university kind of education, it's the formal education that we have. But what does the healthcare industry need? So, and we need a certain implementation kind of activities to bridge the gap, and that's where GHA comes into the picture. So here the training is certain intense. We collaborate with practitioners in real life. So the real world evidence comes into the picture. So you tend to learn the concepts, from what is there in the books and how it gets translated into practice. And to begin with, we have initiated this oncoimmunology course, and we expect to have more courses in the future. So this in a gist is about Healthcare Academy, and myself, Dr. Vinod, I'm the moderator, and I have also handled the cancer biology and certain aspects of immunology for this course, which is more of an introduction. And my topics will later be followed by Dr. Radhesham. I'll give an introduction to sir as well later on, and Dr. Srinivas, my colleague, I'll give him an introduction as well. Please don't flip the slide until I request you to change it. Okay. So I'm from a public health background, and I have transitioned into epidemiology and cancer epidemiology in specific over the last 4 years. So basically, we work with real world data, what comes out from HCG, and as you know, Healthcare Global is a conglomerate of 21 hospitals pan India. So the center of excellence is in Bangalore, and then we have many centers, few in Bangalore and few outside of Bangalore in Karnataka state and in other states in India as well. So we work with real life data, and we try to look for certain causal inferences there, and we publish manuscripts. Next slide, please. So I'll be handling the basics of cancer biology and immunology. Next slide, please. So here, this pictorial depiction is more of the immunity as such. We have a certain innate immunity and we have acquired immunity within the body. So what it means is that there is some amount of surveillance which happens within the body. One, for the outside organisms which come in. One, for certain, rogue cells which are there within the body. Now, I'll be talking about all these immunological aspects and how cancer by itself happens. just because one mutation happens in the gene, or there are some epigenetic factors which promote a certain mutation, cancer will not result. There has to be a certain cell line which go rogue. And within these cell lines, what are the genes which undergo certain changes? And what are these changes? Is it a somatic mutation or is it a germline mutation? That is this mutation which is transmitted through the families, or is it a certain somatic mutation which has happened due to our exposure, maybe to a radioactive material, or because of certain epigenetic mechanisms, that is, we don't do enough physical activity, or we do not have the certain kind of food which is necessary to keep us healthy. So basically, cancer, is a mixture of all these factors put together, and it manifests over a certain period of time. And what are the immunological aspects which are involved here? See, nature gives us certain protection against many things. How COVID evolved, and that's because of what are all the misdemeanors which a man did for COVID to come by. Okay, the same thing. What are all the misdemeanors that we might do, in a sense that why the cancer cell develops within the body and how the cancer escapes the immune surveillance within the body. So these are all the concepts that I'll be talking about in my lecture. So I'll be talking about cancer biology, and then I'll extend my lecture into immunological aspects of cancer. Then we'll be talking about certain innate and acquired immunity characteristics. Then I'll be talking about graft versus host disease. So this in a gist is about my lecture. Next slide, please. So the next part of the course will be handled by Dr. Radhesham Nayak, is the group medical advisor. So he's a senior medical oncologist at Healthcare Global. So sir basically deals with management of solid cancers as well as hematological cancers, and he also does bone marrow transplant. So in his career, sir has been involved with a large number of clinical trials. He has published many papers, and slowly he's transitioning into cancer research with a basic focus on cancer biological research as well as epidemiological research. And sir will be dealing with a large number of concepts, in a sense that the biology involved, the deeper aspects of cancer biology and cancer immunology, and how it translates into practice, into clinical practice. So over to Dr. Radhesham Nayak. Next slide, please. Yes. Just request them to change the slides.
Yeah. Hello. Good morning. I'm Dr. Radhesham Nayak. I am a medical oncologist and hemato-oncologist. And I have about 30 years of experience working in various hospitals, including HCG, which I am there for the last 13 years. And most of the times I've been dealing with large number of cancer patients, both solid cancers and hematological cancers. And we have done large number of bone marrow transplantations also. And in dealing with these kinds of patients, we have acquired vast clinical experience in the immune status of cancer patients and the basic concepts of immunity in these patients. And recently, of course, with the introduction of, say about for 10 years now, introduction of immunotherapy, I think we have had huge experience in usage of these drugs, what are the adverse events, and what are the specific uses of these drugs, and also the resistance mechanisms. Why in some patients, these treatments fail to control cancer, but whereas in some patients, it controls it beautifully. And analyzing these resistance mechanisms, then we also look at the predictive factors. Why, how can we say a particular patient is going to do well with immunotherapy, or should we using them only chemotherapy? And in many of these cases, we have now acquired good efficiency in using combinations, where we use chemotherapy and immunotherapy. We use radiotherapy and immunotherapy. We use biological agents like anti-angiogenic drugs and targeted drugs along with immunotherapy. So these kinds of clinical experience has been got. Along with that, we also have done some basic clinical work, and we have published large number of research papers. We are going to put forward all our experience and theoretical knowledge in producing a adequate program of cancer immunology, where we look at the basics of cancer immunity and why, in spite of the immune attack, cancer thrives, and how cancer controls immunity and allows itself to propagate, and how we can reverse this immune suppression by the cancer and try to control cancer. So anybody who goes through this course will be able to have a very comprehensive understanding of all these aspects. Can I go to the next slide, please? Okay, just as a one of the introduction to the topic, I want to talk about cancer microenvironment. This is not the full analysis, but I want to give you glimpses of what a cancer microenvironment looks like. And we know that cancer comprises of less than 1 to 4% of the total volume of a so-called cancer. And most of the cells in a tumor are not cancerous. So this is what we call as cancer microenvironment. And this consists of fibroblasts. So we call that as cancer-associated fibroblasts, CAFs. We have got immune cells like neutrophils, basophils, eosinophils. We have got macrophages. We have got lymphocytes like T lymphocytes, B lymphocytes, cytotoxic lymphocytes, T helper cells. So variety of lymphocytes which are important for immunity. We have variety of antigen presenting cells, for example, macrophages. And we have got the NK cells, which non-specifically kill the cancer. And then we have got blood vessels with the pericytes and endothelial cells. And we have got nerves and all that. So the whole thing together is the cancer microenvironment. It is very clear now that cancer by itself is not very potent unless it is helped by the normal body cells to thrive. So cancer utilizes the normal cells in the microenvironment to defend itself, befriends those other normal cells, and these cells start working for the cancer than for the body. So that is how cancer manipulates the immune system. For example, cancer recruits the T suppressive cells, what we call as T regulatory cells, and myeloid derived stromal cells. These are cells which are immunosuppressive, and these cells suppress the immunity against the cancer and allows the cancer to grow. Cancer also produces substances like TGF-beta, which can kill the activated T cells. So the T cells will not be able to attack the cancer. And cancer also produces PD-L1 on its surface. And when PD-L1 is expressed, the lymphocytes which are trying to attack the cancer become ineffective. They become lazy, and the tumor escapes. So this cancer microenvironment can be immunosuppressive, and that will be one of the reasons why cancer escapes the immune surveillance, grows, and metastasizes, and body immunity will not be able to keep a check on that. Now we have methods by which this cancer microenvironment can be manipulated. One of the mechanisms is by using chemotherapy. So chemotherapy, one, it can kill the cancer cells, release the antigens, and this antigen presenting cells will present these tumor antigens to the lymphocytes, and lymphocytes in turn attack the cancer. This is one way by which chemotherapy can improve the immunity. The second way chemotherapy works is it can kill the immunosuppressive cells. For example, it can kill cancer-associated fibroblasts. It can eliminate T-regulatory cells. It can take out myeloid-derived stromal cells, which are immunosuppressive. And third is chemotherapy can allow the tumor cells to have HLA shown on the surface so that the lymphocytes recognize it as cancer and kill the cancer. So these are the ways in which chemotherapy can work. And immunotherapy, largely we use anti-PD-L1 and anti-PD-1 antibodies, which are commercially available. And these come and block the PD-L1 expression on the cancer cells, which allows the surrounding lymphocytes to come and attack and kill the cancer cells. So it is very crucial for understanding cancer microenvironment in order to understand how the therapies work to reverse the cancer resistance. So several such topics will be covered in this program, which GHA has kindly agreed to start. And this can be useful for maybe MBBS doctors, pathologists, some surgeons who deal with cancer, and even for the junior medical oncologists, microbiologists, and immunologists. I think, I hope that these people take up this course and benefit from that. Thank you very much.
Thank you, Dr. Radesham, for giving a comprehensive overview of the topics involved. Now I would request Dr. Srinivas to talk about the certain topics that he would be handling. But before that, a short introduction of Dr. Srinivas. He is a medical oncologist who practices in healthcare global. He specializes in managing head and neck cancers as well as gastrointestinal cancers. Dr. Srinivas has been involved with various clinical trials as well, and he has been trained at HCG, and he has been a very illustrious student during his career at HCG. He has been trained with Dr. Radesham as well. And Dr. Srinivas will be talking about immunotherapy in this course. Over to you, Dr. Srinivas.
Hello everyone, this is Dr. Srinivas BJ, medical oncologist. So you heard our director's speech about basics of immunotherapy, how the immunotherapy, immunosuppressive mechanism, immunosuppressive action of the cancer. So usually cancer suppresses the immunity of the body, so that T cells, which are the basic armamentarium for the immunity, will be suppressed and are not able to fight against any cancer, including any foreign bodies. So that is why this immunotherapy, the basics of immunotherapy or immunology, what we call it as, we have designed a course in such a way that from basic to the clinical endpoint, clinically what we are using in the most of the clinical practice, the immunotherapy, and the new era of immunotherapy, because in future year it is going to be the immunotherapy basic research followed by the how the tumor environment is in that tumor, and then based on that devise the therapy for the patient. So it is like a personalized therapy, and personalized immune therapy, immune agents are also have come up. So basically I am going to give a glimpse of mechanism of action of immunotherapy. So next slide. So just a brief history about immunotherapy. So it started in the 2011 with ipilimumab as a immunotherapy agent, which is used for melanoma cancer, and then 2014 it has one more immunotherapy got approved, pembrolizumab and nivolumab. And then 2015-16, so many other drugs have come up. So we now at present we are using immunotherapy agents, immune checkpoint inhibitors. We call it as, we use in head and neck cancer, melanoma, lung cancer, renal cell cancer, Hodgkin lymphoma, bladder cancer, and so many other cancer also coming nowadays. Gastric cancer also we are using, colon cancer, and any organs where microsatellite instability is there, high it is there. So those patients also we are using immunotherapy as a one of the modality of treatment. Next slide. So these are the usually before starting the immunotherapy on the tissue block, we test for PD-L1, MSI, and tumor mutation burden. These give a predictor of whether immunotherapy is going to be effective in that patient or not. Suppose PD-L1 is higher percentage, more than 20, more than 30%, then the immunotherapy is going to be more effective. Otherwise, if MSI, microsatellite instability, we devise it as a high tumor or MSI low. Suppose it is MSI high, without chemotherapy, patient can just be started on immunotherapy. And other parameter we look into in the blood or in the tumor itself is tumor mutation burden. Suppose this is high, cutoff ratio is depends upon in different genomic labs. It may be around 10. If more than 10, then the chances of immunotherapy is going to be high. So this is what we look before starting any immunotherapy agents. Even if it is all of them are negative, in spite of that, somehow we have seen that patients have responded to chemotherapy. When we give immunotherapy and chemo combination, they have responded in spite of these three being negative. Next slide. So this is one of the patient report clinically what we have seen. So this is a case of nasopharyngeal carcinoma. We can see here upside in the first diagram on the left side, patient came with history of lung metastasis, and his PD-L1 was 50%. So we started him with chemotherapy and immunotherapy, and till now, within 3 to 6 cycles of treatment, patient responded very well, and till now we are continuing on immunotherapy as a maintenance therapy, and he has not progressed almost 3 years since we started the treatment. So that is the effectiveness of the immunotherapy what we are using nowadays in clinical practice. Next slide. So this is the basic mechanism. So we have a cytotoxic T cell, which on the tumor cell. So usually whenever any foreign body, including any tumor cells. Next slide. So they get attached to the T cell. They will the T cell get activated. But cancer cell has a support. I mean. Evading the immune mechanism, it will have PD-L1 receptor bind to its surface, and when it binds to the T cells, the T cell get activated. So any foreign body, for that matter, even the cancer cell, when attaches to the T cell get activated. But the cancer cell develops a immune mechanism so that the T cell will get inactivated. Next slide. So this is how the T cell got inactivated, and next slide. Next slide. So this is the diagram. You can see here the in between pembrolizumab, PD-L1 receptor inhibitor. So the green colored is the one on the cytotoxic T cell, PD-L1 ligand, and the T on the cancer cell, it is a PD-L1 receptor. So when it inhibits the immune checkpoint inhibitor, it inhibits the binding of ligand and the receptor, so that the T cell get activated and tries to kill the cancer cells. So that is how the anti-cancer immunity of the body will be activated, and the cancer cell, T cells will try to kill the cancer cell. So this is the basic mechanism for most of the immunotherapy, and in detail we are going to highlight in the immunotherapy immunology courses. Next slide. So one more example of immunotherapy or novel agents is CAR T cell therapy. So CAR T cell therapy is chimeric antigen receptor T cell. So T cell is modified to express tumor antigen. So we can see here tumor cell antigen, and this is the chimeric antigen, and it is engineered in the lab so that it expresses the antigen of the tumor cell, cancer cell, and it is exposed onto the T cell. So when it is injected back into the body, so it will recognize the tumor antigen and it kill the cancer cell. So this has been very extensively used in refractory B-cell lymphoma and leukemias, and we have so many success stories where the refractory leukemias have been cured, completely cured on control of disease with this cell therapy. But it comes with one of the limitation of side effects, that is the self-amplifying inflammation activation, neurological cytokine storm. We call it as a cytokine storm. Patient can go into hypotension, difficulty breathing. So this is one of the example of CAR T cell therapy, which is one of the novel therapy apart from immune checkpoint inhibitor. So like this, so many other immune checkpoint inhibitors and other novel therapies have come up into the clinical practice. That is what we are going to learn in detail in our the immunology course. So this is what I mean. I think most of all of you, it will be benefited for your the clinical research students, the MBBS students, the pathological graduates. So I think most probably it is better to go through the course once and then get well versed with the immunotherapy or basics of immunotherapy. Thank you.
Okay, thank you, Dr. Srinivas, for the elaborate discussion on immunotherapy. You had an opportunity to talk about the concerned topic to the audience. I think basically this course, basically takes you. It's a journey basically, trying to understand the biology of cancer to a small extent. But the immunology of cancer to a larger extent. So we won't talk about the other aspects of immunology, but we try to kind of streamline the concepts into cancer immunology, and then take you through the immunological changes which happens within the tumor microenvironment, as Dr. Radhesham was addressing you earlier, and then progress into talking about immunotherapy, because all that we study and all that we understand eventually has to translate into clinical practice, and it has to benefit the patients. So this course is structured in such a manner, and there's not just one genre of professionals which we are catering to, but cancer is such a large disease. I mean, it's the number one in terms of morbidity and mortality globally, actually, and we have to understand these concepts at a pretty early stage in our careers, and it will help us to probably somewhere connect and collaborate with a cancer researcher later on. So the audience, whosoever are there, I would recommend you to take up this course, and then probably motivate your friends or your colleagues to probably be a part of this course. Beyond all the theoretical discussions and oral discourses, we'll also take you through a few interactive sessions, where we will discuss the patient care issues, and as Dr. Srinivas was explaining, there is a paradigm shift in terms of chemotherapy to immunotherapy and customization of therapy in the recent years, and what beholds beyond immunotherapy is what we could look at, but there'll be a holistic understanding of all the relevant issues. So this in a gist was our webinar today. But yeah, any quick questions, I'll be happy to address.
Doctor, there is one query is asked from the other doctors saying that TILS count will be increased or decreased in cancer.
What count?
TILS count.
TIL.
Yeah, TILs.
TIL count. Yeah, no, there are certain hot tumors and there are certain cold tumors. So when we talk about hot tumors, we talk about lymphocyte infiltration. So in hot tumors, it is increased. In cold tumors, lymphocytes do not infiltrate, so it will be decreased. But if Dr. Srinivas wants to add, a few things to that question, yeah, please.
I think a tumor. I think this must be tumor infiltrating lymphocyte. So some of the tumors will have higher tumor infiltrating lymphocytes, so that indicates a good prognostic marker, and in those cases the chances of immune checkpoint inhibitor working will be better. Some of the cancers we have seen where tumor infiltrating lymphocytes are low, so those indicates that the immunotherapy immune checkpoint inhibitor may not work. So we have to, so that's what we have. Most of the labs have clinical microscopy. They report tumor infiltrating lymphocytes. If it is high, they label it as a hot tumor. If it is low, they label it as a cold tumor. So it depends upon the tumor microenvironment. It is not like all the tumors are high or all the tumors are low. It depends upon how the body's immunity reacts to the tumor, and based on that, the tumor microenvironment, we will have the TILs or tumor infiltrating lymphocytes high or low.
Yeah, so that basically kind of says that every cancer is very unique in its pathology. But there are certain, baseline characteristics of cancer tissue which we need to understand. And that's why we are having this immunology course in place. Yeah, and regarding, we have some information on TILs is also covered in the course. So hopefully that answers your question.
Thank you, doctor. So there is no more questions from our participant. So you can continue on.
So we would want to do this 2-month course, and most of the information is displayed on the brochure. So we will allow you to access the video lectures which have been recorded priorly, and there will be reading material to go along with the lecture. And we have a pre-test and a post-test. So what it basically is, testing. We're not being judgmental there. But we just want to ensure that, what exactly your knowledge was before you took each lecture, and after the lecture, what exactly your knowledge is, because there has to be certain take-home messages. There has to be certain, learnings that you will have to do. So we have tried to design it that way. And, some peer, review.
Doctor, there is a same query regarding from
the deeper concepts. So that's why we have made that as well. So you will have a chance to read through those articles. So for following these sessions, about 15 or 16 sessions of online learning, you'll probably come to Bangalore, and then we'll have an interactive session. For those of you who cannot make it till Bangalore, we are trying to make it a hybrid mode. Whatever the interactive sessions which are happening here, we'll try to telecast that via Zoom or MS Teams, and you can probably view it from wherever you are. So this just will help you understand these topics. And we have listed all the coursework there, so you can probably read through that. And the three of us will be the ones who will deliver the courses. Any questions on the course topics?
Doctor, there is no question right now, but there is a query regarding about the TILs count will be increased or decreased in oral cancer. So what about the TILs in oral cancer?
No, that's what I said, no? And that's what Dr. Srinivas also explained. There's no universal rule which says TILs are increased or TILs are decreased. It just depends upon the pathology of each cancer and how the microenvironment around the tumor tissue is developed, because all the kind of messages which happens between the cancer and the surrounding tissue, and these messages, they could be, cytokines, adipokines, and other things. So how they interact, what is the stroma of the cancer. So all that determines whether a TIL is present or not. And if a hot tumor is there, then we expect the TILs to be there. If it's a cold tumor, then the inflammatory, cells and such lymphocytes or macrophages, neutrophils may not be there. So it depends upon the pathology. So there's nothing blanket which says that TILs are there, TILs are not there. Yes, some of the tumors will have TILs, and if there are TILs and if they are high in number, as Dr. Srinivas said, they become amenable to treatment. If the TILs are low, if they are not there in the tumor microenvironment or in the tumor tissue and other places, we'll have to think about alternative forms of treatment.
Thank you, Doctor, for your kind words. And we have learned more about the certificate course in cancer immunology and immunotherapy. So thank you for your precious time. To conclude, we are very thankful to all the doctors to take your precious time and spend for the knowledge regarding about the cancer immunology. So we are closing our program. So thank you, audience, for attending our webinar section. Thank you.
Yeah, and thanks for all the participants who intend to learn this course. Please be advised that Rome was not built in a day. Similarly, cancer cannot be understood in a day. So it's a continuous process of learning. So it's important to make a beginning somewhere. I made a certain beginning over 4 to 5 years ago. I made a certain beginning to the research work that I do. Everybody has to make, you have to make a crossover. So you should make a humble beginning now. And hopefully you can learn more concepts about cancer immunology, immunotherapy through this course and later on in your research work. Okay, all the very best.
Thank you, Doctor. So we are concluding this meeting right now. Thank you. If any queries, you can directly call to the sales team. We have projected our number in the screen itself. Thank you.